Well, my name's Gul Dadlani, and I'm a pediatric cardiologist at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. And I'm not a cutting-edge researcher like some of the presentations you've seen today. I think when you look across the presentations, you've had a great set of presentations, both on the innovation of congenital heart disease and the science behind congenital heart disease. So what can I tell you about congenital heart disease that you don't already know as a parent or as a patient of someone that has congenital heart disease? And I think what I wanted to go through with you was kind of personal to me as well, because I have a sister that had congenital heart disease, so she had an AV canal. And in 1980, she underwent surgery for that AV canal. At that time, she was quoted a risk of almost 50%. With that, today, we would quote her a risk of less than 5% for that same surgery. She's 35 now, married, and has 3 kids, the last one on the way. So with one surgery, she's been able to go through her life and do very well. But is she cured with that, or does she need long-term follow-up? Throughout her whole life, she's had long-term follow-up. So I wanted to go through how I describe to a parent, be that a mother or father, what to expect for a child with congenital heart disease. And I know that congenital heart disease occurs in a wide spectrum of disease. So it could be lesions like an ASD or a VSD that have a hole in the heart, or it could be as complicated as hypoplastic left heart, where children are requiring multiple surgeries throughout their lifetime. So I made a presentation here today that is generalized in that. So it's not specific to any one particular lesion, but it is generalized across the board, because congenital heart disease as a whole is a very heterogeneous disease process with that. So when we look at congenital heart disease, it occurs throughout the whole spectrum of life. So it's present, this is our pointer. It is present in the womb, it's present in our infants, in our children, and even as adults. So for those of you who don't know, this is Shaun White. He's the Olympic snowboarder. So he has tetralogy of Fallot, has had his pulmonary valve replaced twice. The other picture is Arnold Schwarzenegger. He has a bicuspid aortic valve and has had his aortic valve replaced as well with that. So with congenital heart disease, please take the bubble off your kids. Let them go out, experience life, okay? And try to put as few restrictions on them as possible. Obviously, you'll have to talk to your medical providers on what restrictions to put on them based on their specific disease course. But please try to let them go out there and experience life with that, because they can be successful in life and can really do anything that they want to do with that. In my own personal practice, we have a patient with hypoplastic left heart that's a veterinarian. I also have a kindergarten teacher with a single ventricle who's 64 and just retired. So you can lead very successful lives with congenital heart disease. And again, I encourage you to empower your children to do that. So since we're in the house of mouse here, let's take Mickey here, and let's say Mickey has congenital heart disease. Okay? How are we going to counsel Walt here if Mickey got diagnosed with congenital heart disease, right? What does Walt need to know to be able to take care of Mickey here if he were to have congenital heart disease? So that's what we're going to answer in the next 30 minutes here, okay? So number one is we expect Mickey to survive to adulthood in 90% of cases, okay? And again, that varies based on the type of congenital heart disease that Mickey may have, but about 90% of children with congenital heart disease will survive to adulthood. Kind of a scary picture of Mickey here. Huh? They don't show you that one when you walk into Disney World. When we look at databases that track congenital heart disease, we have the changing demographics, and Dr. Marino talked about this in that there are more adults today living with congenital heart disease. So this is Canadian data, and you can see the trend. And this was as of 2000, but again, these numbers are even higher here today in 2015. But there are more adults living with congenital heart disease today, because out of the 40,000 kids that have congenital heart disease that have require surgery, we're having 90% of those survive and then reach adulthood. So they're living with these long-term complications of having congenital heart disease as they enter adulthood. So what do they need to look out for with that? I think the first thing we need to ask Walt or tell Walt is, are we going to repair Mickey's heart disease? Are we going to palliate Mickey's heart disease? Or are we going to cure Mickey's heart disease? So I would open this question up to the whole audience here. How many of your kids are cured with congenital heart disease? Anyone? How many believe their heart disease is palliated? And your definition is there, to relieve or lessen without curing. And how many are repaired? To restore by replacing a part or putting what was broken to a good or sound state. So we're kind of split between being repaired or palliated, right? In very few cases do we cure congenital heart disease. There are cases, so if you go and put in a device to close a PDA, you can close that PDA off, and those patients may live with no other complications from their congenital heart disease. If you have other simple lesions, ASDs, VSDs, in some cases, those can be totally cured with that. But in most cases, congenital heart disease is either repaired or palliated. And I leave which one up to you based on the definitions that you like there with that. But you can see it referred to as either one. So now let's take Mickey head to toe and think about what do we need to think about in Mickey as Mickey ages here. Again, we watched Mickey be a baby and we watched Mickey be an adult here, an elderly adult. So what should Walt worry about from Mickey as Mickey ages here? So number one question that Walt's going to ask us is, why did my child get congenital heart disease? And that was, I know, one of the questions that came out of the audience earlier. So we have ongoing research looking at chromosomal issues. So we look at Down syndrome where you have an extra chromosome with that. But when you take all patients with Down syndrome, they all have an extra copy of chromosome number 21. But why don't they all have the exact same heart disease? They don't. They have a spectrum of heart disease with that. Okay? We can also look at deletions of our chromosome. So you can have small little areas of your chromosome that get deleted. And again, DeGeorge syndrome is one of those examples of that. Williams syndrome is an example of that. Why don't those patients all have the exact same heart disease? Again, they have a spectrum of heart disease with that, not one single heart disease. We can also look at single gene defects. So there are other disease processes where if you knock out one gene, you get a specific disease. So if you, with that. In congenital heart disease, that's not the case. And let's look at some examples of that. And there was a question earlier about the fetal origins of cardiovascular disease. We care about cardiovascular disease, meaning any disease process that affects our heart or our blood vessels, because 1 out of 3 of us are going to die of cardiovascular disease over our lifetime. Most of us are going to die of having a heart attack or a stroke with that. But today we're going to talk about congenital heart disease with that. But Dr. Barker was one of the first people, and we talked about him earlier. And back in 1992, he published his first paper on this, and he studied low birth weight infants in England. And what he found was they had an increased risk of having adult onset cardiovascular disease. So they had increased risk of having diabetes, hypertension, coronary artery disease, or lung disease, not congenital heart disease with that, okay? But if you're born low birth weight, or you have a small for gestational age infant, meaning less than the 10th percentile at birth, they are at risk of having these illnesses as they age with that. And we continue to learn more about that. We also know there's a whole field of epigenetics, which looks at, although our DNA is there in a person, it gets modified by our environment. So stress during the pregnancy or changes to that fetal life can change our DNA. You can add little proteins called histone proteins to our DNA that may turn on or off a particular gene, which can then predispose to cardiovascular disease. And if you look at an animal model of that, you can look in rats, and this study looked at rats, and they growth-restricted rats. And if you growth-restrict a rat, it changes the methylation pattern, or those little proteins that get added to our DNA, and it increased their risk of having diabetes or hypertension by having less pancreatic cells or less renal cells available to that. So again, that's why looking at that fetal environment may modify our congenital heart disease in the future with that. We can also look at our chromosomes as well. On the end of our chromosomes are these things called our telomeres. Those are the little red parts here. These are our zippers. When a cell wants to replicate, it has to duplicate your chromosomes to make that new cell. As it does that, you lose part of your telomere every time a cell replicates, okay, with that. And the length of your telomeres will tell you what the longevity of your cells are going to be. So if you're female in the room, you probably have longer telomeres than your adult partners sitting next to you. So that's why women tend to live longer than adults with that. But we're also looking at this in other disease processes as well. Now let's look at congenital heart disease. What are the fetal origins of congenital heart disease? We don't know yet, okay? Let me just put that out there. But what do we know? We know that the heart forms between weeks 4 and 7 of gestation, okay? Again, many times before a woman knows that she's pregnant. And the heart starts off as a tube, and cells have to migrate down that tube and get to the right place to form those valves and all the chambers in the heart. And there's certain proteins that are required to be signalers of how those cells migrate down that tube. So they studied this, and they found that in adults, there's this protein called NKX, which is common in adults with atrial septal defects. So they went and took that into a mouse model, and they knocked this protein out in mice. So if we knock that protein out in mice, you would expect that every mouse had an atrial septal defect with it. But what they found was that some mice had a ventricular septal defect in this perimembranous region, some had a muscular ventricular septal defect, and some had an atrial septal defect, all from one gene knockout, okay? We go on and we go look at those mice then, and then they studied these other proteins in the mice, and it really took a 2-hit theory to get congenital heart disease here. So it takes at least 2 hits. And if we look at this, the black line here are muscular ventricular septal defects. So if you had a muscular ventricular septal defect, you needed NKX plus this other protein to be knocked out. If you had a perimembranous defect, you had to have NKX plus these other 2 genes to get knocked out. But this isn't 100%, right? When you look at this, you still have a spectrum of disease here. So it may be more than a 2-hit theory that causes congenital heart disease when we look at it. So again, we continue to learn more about why congenital heart disease happens. Is it genetic? Is it then modified within that fetal environment? And we have to put all these pieces together. But that's why Mickey had congenital heart disease, okay, today in 2015. When we talk about Mickey from head to toe, we're going to look at his head and his central nervous system. We know that we can have delayed milestones. We know that we can have visuospatial deficits. We can have cognitive impairments or learning deficits, as we've talked about with that. We know that we can also have strokes and MRI-related changes. We can have seizures as well due to hypoxic injury to our brain with that and abnormal brain development with that. All of those go to children with congenital heart disease needing extra help in schools many times with that. And how about behavior with that? So how does is Mickey going to be mad and grumpy about having congenital heart disease? Or is Mickey going to have this outgoing personality and not care that he has congenital heart disease, right? So our children with congenital heart disease fit along that whole spectrum with that. And we have to help them adjust to having congenital heart disease. How do they accept that they have their scar and they walk out there every day and accept that and are proud to do that? My sister had to go to the prom. She had to wear a dress, a low-cut dress, showed her scar. It didn't bother her. She was able to walk out there and say, this is part of me. I'm going to go out there and do this. And that's what we got to empower our children to go out and do. We can also have hearing-related problems. So is that from surgery? Is that from having congenital heart disease? Is that having from just other related birth defects? So especially if you're syndromic, if your child has congenital heart disease with a syndrome. You can have sensory neural hearing loss, which is if we're looking at our ear back here, going up to our brain. Or we can have a conductive hearing loss, where we have fluid that builds up. How many people have children with congenital heart disease that have had ear tubes placed in the room? Large number, right? With that. If we don't clear that fluid out, right, their hearing will be less, their school performance will be less. This is an issue for us in our kids. The only way we know is go look for it, right, with that. So how about other parts of our body? Our teeth, right? How many people have had to make that urgent phone call to our cardiologist office to say, I'm going to the dentist today. Can you please call me in some antibiotics, right? We get a couple of those a day, right? So we even had one, we had to call it in within minutes of them going to the dentist just the other day in our office. But it is an issue for kids that have congenital heart disease. So who needs antibiotics before they go to the dentist? So if you've had prior endocarditis, which is an infection in the heart, you need it for your whole life, okay? Just count on it. You're going to get it. So take antibiotics before you go to the dentist, okay? If you've had a heart valve replaced, you need it, okay? You have artificial tissue put into your body. You got to protect that because the theory is as you go to the dentist, you have the potential for bacteria to get from your mouth into your bloodstream, circulate through your body, and then sit on an abnormal heart valve or patch that's been put into the heart with that. If you have unrepaired cyanotic heart disease, you need it. If you've had repaired congenital heart disease, a VSD or an ASD, you need it if it's less than 6 months. After 6 months, if you put a patch into the heart, that patch usually endothelializes, meaning that the body creates a layer of tissue over top of that patch or device that's been put in. So after 6 months, you don't need it if there's no residual hole there. Or if you've had a heart transplant, you also need it with it. Why don't we give antibiotics to everyone, though, with congenital heart disease? So prior to 2007, we did. What they found, though, was that if you have congenital heart disease, okay, your risk of getting endocarditis was about the same if you were getting just that one dose of antibiotics when you went to the dentist. Because your real risk was there every single day, because if you go home and floss, right, you're going to see some blood with that. If you brush your teeth real hard, you're going to see some blood with that. So what makes the most sense is keeping good health of your gums with that all the time. And then we only give antibiotics for these specific lesions with that. So not everyone needs antibiotics before a dental procedure with that. And I would encourage you just to talk with your cardiologist about your child's specific heart disease or your personal heart disease. Now, how about dealing with our scar, right? As we move down our body here. Mickey has to deal with having a scar if he has congenital heart disease. So we know that babies, their scars will heal very well and easy in most times, right? The older we get, the less well our scars heal. So if you have to have redo surgery as a teenager or an adult, your scar will be thicker and a little bit more prominent than it was if you had neonatal heart surgery with that. You can also develop keloid formation, which are thick scars. Many times those are hereditary, so that may run in the family. So if you are someone that has a family history of forming keloid formation, you want to make sure your physicians know about that. And then there's the whole emotional acceptance part of this, right? These children and adults that have congenital heart disease have to accept that this is part of their body, and they got to be proud of that, okay? This is what kept them alive, to be able to do all the things that they're doing, and we got to empower them to accept it. Also, living with congenital heart disease can also cause a condition called pulmonary hypertension. Pulmonary hypertension means that you have high blood pressure in the lungs. So if we were to map out our heart here, if this is the right side of our heart, we have our right atrium, our right ventricle, we have our pulmonary arteries, we have our lung, then we have our pulmonary veins coming back to our left atrium and our left ventricle. If we have left-sided heart disease, right, blood flow can't get out of this left side, so it's going to back up onto the lungs and cause higher pressures in our lungs. If we have primary lung-related problems, so if we've been intubated for a long time, we can develop scar tissue in the lungs. If we have recurrent pneumonias, we can have scar tissue in the lungs. Or we can have primary problems in the lungs where these little vessels don't grow well, especially in children with Down syndrome with that. Or we can have surgery to our arteries going to the lungs. So if you have tetralogy of Fallot and have discontinuous pulmonary arteries where these pulmonary arteries are abnormal, again, you can be a setup to have pulmonary hypertension where you have high pressures in the lungs. Other lesions can also do that by causing increased flow to those arteries with that. So patients with transpositions will have increased flow to the lungs. Patients with single ventricles, because we've taken the vessels off that normally supply the right side of the heart and connected those directly to the lungs, those lungs are under higher pressure and also have risk of clot formation over time with that. But all of these lesions can lead to having pulmonary hypertension. When we look at pulmonary hypertension, our lungs grow from birth to age 7 or 8. And when we're born, we have about a third of our lung tissue. The other 2/3 grows between birth and age 7 to 8. Most of that growth is between ages from birth to age 2 to 3 as we go along with it. So making sure our kids don't have respiratory infections in those first couple years of life is important. For those of you who have neonatal patients under a year of age with that, making sure they don't catch RSV is a big important criteria, because if you knock off growth in this critical stage, you can lose these precious lung cells in there with that. So, and what symptoms do we develop if we have pulmonary hypertension? Well, we can develop dyspnea, which is shortness of breath, or fatigue. How many of your kids are out there all the time as elite athletes with congenital heart disease? Not too many, right? So many of our children with congenital heart disease will self-limit themselves with having congenital heart disease. So trying to pick up, are you short of breath with exercise or are you fatigued with exercise, is difficult in the congenital heart disease population because they already self-limit themselves with that. So you have to go looking for this in order to pick it up. So for patients with single ventricles that have Fontans, the only way you're going to know is you got to go put a catheter in there to go measure those pressures. Those devices that they were showing to measure those are a next step in being able to monitor those patients effectively with that. Syncope can also occur. It's less rare, or it's less common with that. And patients with Down syndrome are also, again, at risk of having pulmonary hypertension. How about endocrine? Endocrine problems. So Down syndrome and DiGeorge syndrome are two syndromes that can be associated with thyroid dysfunction, and in DiGeorge syndrome can also have abnormal calcium regulation. Your symptoms are there that you'd go look for, but again, you won't know unless you go look for it. So you got to make sure they get annual thyroid function in those particular conditions. So how about from the heart? What do we worry about if Mickey got repaired and is now living with his heart disease? Okay? And it doesn't really matter what heart disease he had repaired. Let's go through the whole list of what do we worry about with that. We know that we have to counsel Walt on Mickey's valves can deteriorate as they age. Each one of us, if we're born with normal valves, our valves can wear out as we age. If we've operated on a valve to try to repair or palliate that valve, it can wear out sooner. So you can have leakage of valve or need for valves replaced. If you are going to replace an aortic or mitral valve, you may also need blood thinners with that. You can also develop aortic root dilation if you have connective tissue or weaker tissue with that and have risk of aneurysms with that. And did our outflow tracts grow well, or do we need extra surgical intervention or catheter-based intervention like the cutting balloons that they showed today? If we've had patches placed in the heart, we can also develop abnormal heart rhythms or even need pacemakers over time. We may be at risk also of early coronary artery disease, early hypertension, or have progressive ventricular dysfunction if we've had multiple surgeries where our heart's ventricles start to wear out with that over time. I always like to think of our heart as a box with 4 chambers. So we have our 4 chambers with that, and we can look at our interaction between our heart and our lungs easily that way. Again, all of our valves can wear out with that and may need to be replaced depending on what congenital heart disease we started out with. Aneurysms are also a big thing to go look for, especially if you have a child that's had coarctation, repair, or disorders that affect our aortic arch. In those cases, they can be at risk of aneurysms in the head or in lower part of our body over their lifetime. The only way, again, you'll know is go look for those. You can also have coronary artery-related problems. So for those of you who don't know, our coronary arteries are little arteries that come off of the aorta, and they supply our heart with oxygenated blood. And these are our arteries that cause heart attacks. And as adults, we build up plaque in those arteries. But if we've operated on these arteries or had to move these arteries, like in transposition patients, those arteries can have scarring at those, and you can have narrowing within those arteries. So you have to watch those arteries as patients age with that. You can also have rhythm-related issues. These are typically related to either the electrical system in the heart wearing out or where we've previously put patches in the heart with that. We can also develop heart failure. So if the left side of our heart starts to fail, we build up our fluid back into the lungs. If our right side of our heart starts to fail, we build up fluid back into our liver and the rest of our body, so we get edema in the body. With that, for all the single ventricles in the room, you can, if you're a Fontan patient, again, these arteries are connected directly into the lungs with no pump. So where you're going to build it back up is onto our liver with that. So we can also have musculoskeletal related problems. So here's a picture of Mickey with Halloween. Here's our scoliosis that Mickey can develop with that. So we have to go look for that as well with that. We can also have GI-related issues. So if you have an infant, many of our infants have G-tubes. So I put a little picture of G-tubes up here. But feeding can be a big issue for kids, especially with complex heart disease with that. And watching our liver as our children age is also important for these patients. Congenital heart disease is our #1 form of birth defect. Renal-related issues and genital urinary tract-related issues are #2, so we also screen for those over time with that. And that can, if you have kidney-related issues, it can lead to hypertension. We can also have peripheral vascular disease from having prior cardiac catheterizations and lines in place. So having narrowing of our vessels as in our vessels out into our body. This is a picture of a patient who has a narrowing here. This is our aorta coming down, and then the vessels going to the leg with that. We also can have venous-related issues. So this is a patient with bad varicose veins later on with that. Lastly, other things we want to just touch on real quick are athletic participation, right? What can my child do with having congenital heart disease? I would make sure you talk with your physician about this. This is really specific to each individual child's heart disease with that, but congenital heart disease does put them at having increased risk of having sudden cardiac death with that. And how about marriage and planning? As Mickey gets older, he may want to meet Minnie and start a family, right? What is the risk of them having another child with congenital heart disease? This study in Italy looked at 1,600 pregnancies. If you had one child affected, your increased risk was 2% with that, just by looking at fetal echocardiograms. If you did a follow-up echo at 6 months of age, that risk was about 4%, which is what we will talk to families about in prenatal counseling, that their risk is typically under 5% for having another child with congenital heart disease. Although there are some lesions that have a higher risk. So if you have left-sided heart disease, aortic stenosis, coarctic, hypoplastic left heart, those can be higher and run dominantly with that. We'll skip some of these in the face of time. Fetal echoes can be done at 18 to 22 weeks to give us great pictures, like Dr. Rychak said. And I wanted to leave you with that congenital heart disease and cardiovascular disease is really a spectrum of disease, and it is throughout the whole continuum of life, from the fetus through childhood all the way through to adulthood, and that patients with congenital heart disease require lifelong follow-up, and they really need a comprehensive team to be able to manage all the organ systems that are affected there. And again, I want to leave this on a positive note, and that 90% of your kids are going to make it to adulthood. And what we as medical providers want to do is to decrease those associated morbidities that now face these patients that are living with congenital heart disease every day. So I thank you for the opportunity to talk here today.